Today we're going to talk about acute ischemic stroke treatment and whether we're there yet or not. And it's a continuous evolution over the last 2 decades. And the reason is a lot of money is going into stroke research because it's a pretty catastrophic disease. It's the 4th leading cause of death. It used to be the 3rd, so we're doing something right. It's actually the 4th leading cause of death now. But the problem is it's still the leading cause of serious long-term disability. And that's hopefully what the message today is. If we get you into the hospital fast enough and we can treat you, you won't be one of those who would be disabled or your loved ones or your family members. Each year about 800,000 people suffer a stroke, and 600 of them are first attacks and 185 are recurrent. So that's another problem. Why are we having so many recurrent attacks? And on average, every 40 seconds, someone has a stroke in the United States. So out of all the types of strokes, we're going to talk about ischemic because it's the largest. 87% of all strokes are ischemic, which means there's a blood clot in a blood vessel. There's other types like, rupturing a blood vessel in your brain. We're not going to go through any of those right now. So this is a list of all the randomized controlled trials that were done. And as you can see, the first few were negative. All the trials that were done to prove that IV clot buster, IV TPA works, were all negative. And the main reason was because they were trying to use cardiac doses. We had MI literature and TPA works for heart attacks. When you try to use the same dose for a brain, the brain doesn't like it. Basically, you got a lot of bleeds and a lot of complications. So tailoring the dose, as well as tailoring the time window where we can treat patients, got us the NIH Trial, which was an NIH-funded trial, US trial, and it was the first positive trial for IV TPA. And that's basically the bottom one. And then it almost took another 7 years to get another positive trial. So to review that NIH trial, that landmark trial, basically you had 624 patients. And they were enrolled within 3 hours, and they were randomized to the IV clot buster versus nothing. And if you look on the top row, it's improvement at 24 hours. So you had 47% of patients who got the clot buster improved within 24 hours, and 39% of the placebo patients. The key wasn't at 24 hours, the key was at 3 months. How did patients do after 3 months? And they used a bunch of different indexes to really make sure that they weren't missing anything. And favorable outcome defined by the modified Rankin scale. So basically these patients are completely independent, can walk, talk, do everything on their own, all their activities of daily living. 43% of those patients came out with a good result. Whereas if you got placebo, only 37% of those patients ended up with that good outcome. So there's a pretty significant difference. Now it came at a cost, obviously. You still had, even though the majority of patients did better, you had some patients who did worse. And you had 6% of patients had a bleed versus only 0.6% of the placebo patients. So currently, it's the only one drug that's approved for acute ischemic stroke treatment. And successful administration of IV TPA has been proven to improve long-term outcomes. We looked at 3 months and they've looked even further. And it reduces the cost to the healthcare system. So obviously we all know healthcare costs is a big issue, big hot topic these days. So we did this analysis using the Premier database, and it looked at all strokes all across the country. And this is obviously just a snippet, 5–10% of the patient population. So for example, 54,000 patients were pulled in 2001, and out of those, only 1.6% of them were treated. That's pretty poor. Now then, there started becoming these JCO, or Joint Commission certified centers. That started around 2003, 2004, and by 2006, you're still only treating 3%. We're only treating 3% of strokes. That's very poor. Now, according to the NIH, we should be treating 15 to 20%, because 15 to 20% of patients come to hospitals within 3 hours. Now, at the Valley, that's not true. At the Valley, it's like 5%. Patients are not coming in on time. They sleep on it. They say they think they're going to get better. They come in the next morning. It's pretty bad. And that's why, unfortunately, you can't treat them. You can't treat them with anything, even the more advanced treatment options I'm going to discuss later. So you need to try to come in as soon as possible. Now, if you increase the time window from 3 to 6 hours, according to these national studies, you go from 15% to treating 30% of stroke patients. Imagine if we could treat 30% of those 800,000 patients. It's a big chunk of patients. And obviously, we all know stroke care in rural areas is continuous. I mean, it's underserved. In our area, there wasn't really. Valley Baptist was the first primary stroke center. And now we have a couple of stroke centers in the valley, but it took a while just to get to that level. And now we're the only comprehensive stroke center. And hopefully we'll bring that advanced treatment to the valley. So symptom onset. Patient develops face weakness, arm weakness, leg weakness, slurred speech. They call 911 and EMS comes in. The key is that they have to call 911. We can't bring them to the hospital if they don't call 911. Once the patient comes to the hospital, you have in-hospital protocols. Dr. Parada has done a great job building in-hospital protocols. The ED does a great job triaging these patients, getting the IVs in, getting the patient a CAT scan, getting all the necessary steps, and if the patient's a candidate, they give them the drug. So all that's available. The problem is number one, public awareness. We're not getting the patients in fast enough. So hopefully today, everyone's homework is to tell a friend, cousin, nephew, son, brother, if you have any of these symptoms, you immediately call 911. So this is actually multiple figures that were put into one. And what they did is they did a meta-analysis of all the large IV TPA trials. And what they found was that time, which was on the x-axis, if you want a good outcome, as time goes on, you have less of a chance of having a good outcome. You have less of a chance of any good endpoint. You have an increased chance of mortality. So you're more likely to die if you don't get treated fast enough. And you're more likely to have a bleed, which is probably why you die. I like this table. It's a little busy, but we're just going to focus on the top four numbers. And basically, the first column is the analysis based on the NIH trial. So 1 to 3 hours, these patients were given IV TPA. And the benefit per 100 patients is 32. So for every 100 patients who get IV TPA, 32 will benefit. Only 3 will be harmed. And that's what patients need to understand. Sometimes they're like, oh, I don't want the clot buster. I heard it causes bleeds. Well, if your chance of getting a bleed is 3 out of every 100, but your chance of improvement is 33, those are pretty good odds. Now, the ECAS trial was a European trial, and we'll go through some of the details of the trial in a little bit. But basically, that expanded the IV TPA time window to 3 to 4.5 hours. And it's endorsed by the American Heart Association, but it still does not have US FDA approval. So FDA approval is only for 0 to 3 hours. Yet we do treat some patients in that extended time window if we consent them and explain to them the trial results. And that's basically what I was just mentioning. The ECAS trial extended the IV TPA time window. Now they did 821 patients, randomized. They only looked at 3 to 4.5 hours, because we already know it works within 3 hours. So they only looked at patients that came in within 3 to 4.5. And the same thing, they randomized them to IV, clot buster, or nothing. And 52.4% of their patients who get the IV treatment had good outcomes, which is, I mean, if you look at the number, 52%, it's great. It's much better than the 0 to 3 hours in the American study. Here's the problem. The placebo patients did 45%. That's almost as good as the American trial with the drug. So the key message here is drink a lot of red wine like the Europeans, put olive oil in everything, and you're less likely to have a stroke. The other big thing in this trial was their hemorrhage rate was very low. They only had 2.4% of patients had a hemorrhage, basically a bleed in the brain. Why is that? They changed the definition of hemorrhage. They said the patient had to be significantly worse and have a hemorrhage. He just couldn't have a hemorrhage. So they kind of fudged the numbers. And that's why it's not FDA approved. So here's a trial that we did. It's an analysis kind of prospective study we did at University of Minnesota. And the point was to look at the drip and ship method. Basically, if a patient comes to another hospital, rural hospital, we had 26 small hospitals refer patients to us. So if the patient comes in at another hospital, gets evaluated at the ER, they call me, I look at the CAT scan, okay, give the IV TPA. They give the IV TPA, ship the patient us. Then if the patient fits the criteria for advanced treatment, he'll go on to get that advanced treatment. If not, he gets admitted to our ICU. So we had 69 patients who came in through the emergency room. And this is not 69 strokes. This is 69 patients who got IV TPA. This is to kind of give you an idea. This is one of our university hospitals. We gave, I think, 20 IV TPA last year at Valley Baptist. And we're a pretty big hospital, 400 something beds. They gave 69 IV TPA in the hospital. And then they received another 35 via drip and ship. So this is a very big stroke center. 57% of those drip and ship were by air. Actually, 43% were by air, 57 by ambulance. And they all come to us. So we said, okay, do these patients do better or worse if they came into that comprehensive stroke center or they went to the closest hospital that can handle IV TPA? Basically, the drip and ship patients were older, and they had, everything else was almost statistically significant. It took them longer to get IV TPA, which makes sense. At a comprehensive stroke center, you have a bunch of guys like me running around wanting to give TPA. At a rural hospital, you got an ER physician who's busy doing 100 things, an MI, broken leg, and he finds the time to do the IV TPA. So there's about a 14-minute difference in IV TPA. Their NIH stroke scale at 3 months is actually, there's a trend towards lower in the drip and ship patients. And with the modified Rankin, same thing, fully functional, independent at home, there was a trend towards lower. So basically, if anything, they're the same, but there's actually a trend towards even better outcomes. And the point is you get IV TPA faster. The key is to get treated fast. So are there additional treatments? Well, there are. Endovascular, and that's what we're going to focus on today. And what's the role of endovascular? There's a lot of studies that showed if you have a large clot burden, if I have a big, chunky, thick clot in the carotid, I don't care how much IV TPA you give me, it's not going to open up. So you need something to pull it out or break it up. And that's where endovascular comes in. So this is using the data from that NIH trial, and they looked at the sites of every single clot in those patients. And they saw that if the patient had a distal MCA, the vessel that's right behind your eye, supplies your motor function. If you had a distal MCA lesion, 44% of those opened up within 2 hours. But if you had a carotid terminus, terminal ICA, which is where the two blood vessels split off, you only had a 6% chance it was going to open up. And then you only have an 18% chance of a favorable outcome. So you're more likely not to do well. So that's how endovascular started to come up. What do we do? What can we offer patients with these big clots? So this was a study we published last summer, and we looked at the trend of endovascular treatment across the country. And basically, the numbers kind of match that earlier trial I showed you. There's about, the blue columns are 3.4% in 2009. That's IV TPA, which matches all the other data. It's around 3%, 3.5% we're treating with IV TPA. With endovascular across the country now, 0.6%. So it's nothing. It's still a small percentage of total treatments. But later on, I'll show you the numbers that came out of University of Minnesota. And most large university setups follow almost the same demographics and all the same statistics. You end up treating a lot more patients. The reason it comes out to be 0.6% is there aren't that many hospitals that do it. I mean, in the Rio Grande Valley, there was nobody who did it. I came, and now there's one guy who does it. So it's slowly growing across the country. The advantage is obviously increased recanalization. We can open blood vessels faster. We can open them. I mean, we're going to use a mechanical device. We're going to suck this clot out. We're going to break it up. We're going to do something to it. But we're going to get that clot out. Enhanced safety. We use much smaller doses. We take a little catheter, a little tube up there. We kiss the clot. We give a little drug. We give 1, 2, 10 milligrams. Whereas when you get the IV drug, you're getting 80, 90 milligrams. It's going throughout the whole body. You got a scar here. You had recent surgery. You can't get it. Or if you ever had brain surgery, you can't get it. Because it's basically going to increase your likelihood of a bleed. So we don't want you to die of bleed just to save you from a stroke. And then obviously mechanical interventions are possible. The disadvantage is limited personnel, limited facilities. Like I said, now Valley Baptist is the only comprehensive stroke center in the valley. There's delay in drug administration. It takes time to get the patient, 1, to a comprehensive stroke center, 2, to the cath lab, 3, to get your little tiny tubes up there in order to treat the patient. So everything, there's obviously a time delay. And then there's additional risks. I mean, you're going in somebody. You're going to go play with his brain. You're basically taking these tubes inside their brain. It's an invasive procedure, so it carries some risk.